going on, guys, and welcome back to the world's okayest physical therapist podcast, hosted by me, Dr. H. Please don't forget to check out the Patreon if you haven't already. There is a free option. Please consider joining just because it is where I put some of these things out way earlier than you see them on YouTube and Rumble and Spotify. Please consider checking out 10,000 for the shorts, the t-shirts, and the pants. And hopefully we can get some more sponsors coming in onto the show. I've been emailing a whole bunch of people. We'll see if we can get some more people on the show. But today we're talking about episode 3 of the Is PT Unprofessional Now? An unfortunate podcast about an unfortunate topic. So today we're going to be delving into the degrees, the power, and the patient care, the funding crisis in rehabilitation medicine, which is really going to be a focus on why physical therapy became a doctorate level profession. To answer that, we have to, of course, go to history. We have to see what physical therapy education looked like before it became a doctorate level program. In the 1960s and 1970s, physical therapy programs in the United States were typically a bachelor's degree. Students received training in kinesiology, therapeutic exercise, basic modalities, and general rehabilitation concepts. By the 80s and 90s, programs started shifting towards master's level education. But that begs the question, why? And in short, the answer is the following three things. The level of scientific research was increasing. Anatomy and neuromuscular science required more hours because of this more research. Rehabilitation medicine was expanding into neurological, pediatric, cardiac, and ICU care. But what does this mean in plain English? Well, it means the more research that we do, the more studying that we do in the healthcare profession, the more correlations we discover, the more connections we see to things, and the more we understand the human body, the more there is to teach. So it turns out the more that we discover, while it does accelerate some technology, right, like computer technology stuff, the more that we understand about the human body, the more there actually is to teach the upcoming generation of doctors. And as far as we can go back to, the 1600s, the 1500s, when colleges, I think, were first really coming off the ground, there wasn't that much to teach. In fact, not compared to today. The idea was we're going to get you up to speed to get you to be able to know and practice what you need to know and practice to go out into the field and make a difference. But the more that we delve into the human body, the more that we discover about neurology, pain science, how different surgeries, all these different things, like tendon loading versus muscle loading, whatever. All these are things that take longer now to teach, but we expect to teach it in the same time frame. And this kind of poses a problem because now you're having to crush all the most recent studies and data into the smallest data points, the smallest bite-sized information that someone can absorb to then become a practicing clinician instead of truly taking the time to understand a study and how it was done, who's done it, and all those things. All that critical evaluation skills, they're not as prioritized as just going through and understanding the correlations between things. And this is particularly true when it comes to the different specializations like neurological, pediatric, cardiac, and ICU. Well, if you know that as a PT, you're going to be going into one of those specific areas, guess what? You still have to learn about all the others because there's the potential that at some point in the future, you might not work in your preferred setting. You may have gone to school to be a pediatric physical therapist, but you end up being one who works in general outpatient ortho anyway. And so the degrees still have to cover everything instead of letting you specialize. There's something else besides this volume of knowledge that we have growing and then trying to be forced into the brains of young PTs in the same time period as it always has. Besides that going on, there's also something else going on. The medical system, the healthcare system, the labyrinthine Byzantine thing, you thought I wasn't going to sneak that in, didn't you? The labyrinthine Byzantine thing that we call the American healthcare system was also becoming more medically complex. People began living longer. They started surviving injuries and diseases that typically they didn't before. They started having surgeries that were previously considered either fatal or impractical or impossible. and they started presenting with layered pathologies. That means they would have things like diabetes, heart disease, and several other things on top of that. What we know now is comorbidities, right? So in the 60s, obesity was not the issue that it was today. Neither was diabetes, right? We didn't have, it's just like if you go back 500 years, we didn't have a way to treat diabetes. So people that had diabetes didn't live very long, unfortunately. Now they live long, happy, healthy lives, and that's a good thing. But we also know how to treat a patient who has diabetes because that means they're likely going to start having nerve damage, amongst other things going on. So the question, as we have all of this knowledge that we're trying to now absorb at the same, um, we're trying to indoctrinate into the next generation in the same time period, 3.5 years that we've always had, instead of expanding that and saying, okay, well, now the sheer volume of data we have to teach you is technically 5 years worth of data. So we're going to make it a 5-year degree. No, no, no. We have to make it the same. We have to make it affordable, and we have to make it quick to get you out into the real world. We're going to keep it at 3.5 years. But you're going to have to learn so much more than even the previous generation 20 years ago. That's problem number one. Problem number two, now the entire healthcare system is more complex, and you have patients that have way more conditions than someone was even seeing 30 years ago. So the question becomes, are we training physical therapists to be technicians, or are we training them to be medical practitioners? And this is where the APTA enters the stage. The APTA vision in the 1990s became the central focus of physical therapy, basically. In the 1990s, they came up with the APTA Vision 2020, which we talked about in previous episodes, and the goal was clear. Physical therapies were not to be technicians, they were to become practitioners of choice with direct access to care. To get that, to be available for anyone to walk in off the street and to be treatable in a physical therapy clinic, that means that you had to be able to screen from serious medical conditions, what we call medical red flag conditions, things like cancer, things like atlantoaxial instability, things like meningitis, all these sorts of diseases, all these sorts of conditions. We had to be able to know the presentation of them and memorize them and have them well ingrained in our brains. That way, when a patient comes in, sits down, start saying things like, "I have unrelenting night pain. I cannot control my bowel and my bladder anymore, and I cannot, or I can barely walk. And 2 weeks ago, I could walk just fine." That trips every single wire in the PT's brain for, I need to send you to your doctor because something else is going on other than would be required by physical therapy. That also means that we had to be able to perform differential diagnosis. And that means we have to have two different ideas, two different theories at least, two different conditions, and we had to be able to know them well enough to tease apart which one was more likely. A really good classic example is this a tear or is this a tendonitis, right? Knowing the different presentations of the two and how to treat them, very important. Understanding pharmacology, this is huge because when a patient shows up taking specific medications and says they're dizzy, you have to be able to take a look at that medication and say, yes, yes, I can see the medication that you're on, fill in the blank, likely can cause dizziness. Or, oh, your blood pressure is super low. Okay, let's take a look at your medication. Oh, I see you're on blood pressure medication. Did you take your blood pressure medication today? Oh, you accidentally took two. Let's stop right here and call your doctor because you probably shouldn't have taken two. You probably should have taken one. If you miss a day, the idea isn't to take two. Believe it or not, that's a very common conversation to be had in the clinic. Interact with insurance and legal standards. That's another huge part. Insurances are not the same. They are not uniform. They are different. Different insurances have different things attached to them. Some will require referral, meaning that they have to go and see their primary care provider and then come see you. Others do not require referral. They can come directly to you. Knowing the difference, too, of what they expect, right? Some insurances might only give you 10 visits. Others might give you 50. Others might give you 120. All of that is things that you need to know. And then specifically also for government healthcare, and that would be TRICARE, Medicaid, Medicare. They have specific standards that they want fulfilled, and you have to know how to do your documentation to meet those standards. And then finally, knowing how to treat without a physician referral. which is okay, this person has showed up, you've evaluated them, you've determined what's going on. Do you have to refer them out to go back to a different doctor or a different specialist because you think that would be effective? Or are you going to treat them, and how are you going to treat them? And what can you expect your treatment to do to impact them? You can see that was a lot of words. I'm out of breath. That's a lot of things that the APTA was pushing for physical therapists to be able to do. That's why the APTA pushed towards doctorate level competencies. And by 2015, the transition was complete. Entry level physical therapy programs in the United States were all doctors of physical therapy. For the first time ever, physical therapists were trained as autonomous providers just in case they needed to be. But that decision has consequences, and that is exactly what brings us roadmap wise to what happens with the Board of Education. What the critics said then was that the shift to the doctor of physical therapy was not necessary. It was not universally welcomed. Not everybody in the physical therapy world wanted it. And here were the most common arguments, the top four. Physical therapy is not a medical doctorate. Some argue doctorates should remain with MDs, medical doctors, DOs, doctors of osteopathic medicine, and PhDs. That was the first argument. Let's let the responsibility of diagnosing all these issues and all these diseases, let that stay with the doctors. They just refer to us. We are the movement specialists. We will just treat. And we will be very good at treating, but we don't have to worry about everything else. We don't have to be autonomous. We don't have to have our fingers in everything. We just need to have the doctors send them to us so we can make them better. And that allows the burden to be on them. They have to screen them for cancer. They have to screen them for those things. For us, it just has to be, can I get them better, and how fast can I get them better according to whatever condition they have and whatever protocol the surgeon has given me. Argument number two, this will increase student debt without raising wages. If I could have an air horn go off, I would have it go off right now. This one proved exceedingly unfortunately accurate. The PT debt burden rose, but salaries did not rise proportionally. And if you look across the economy right now, it has not really risen for anyone proportionally. But to become a doctor of physical therapy and to not get any sort of salary that looks proportional to a doctorate level education is especially bruising and crushing. And it definitely can lead to the strong incentivization to leave the field, which is what we talked about last time, about 10% of PTs leaving the field every year. Argument number three, insurers don't care about degree levels. That means like all of your healthcare insurance companies, they don't care. They want to reimburse at specific levels, and they aren't going to care if you're a doctor billing for that or if you're not a doctor billing for that. Either way you cut it, the truth is, now that we're a doctor level profession and physical therapy and have been for 10 years, it turns out the reimbursement structure has not changed. It hasn't changed. It hasn't gained us anything from insurance. And like I talked about previously, it's kind of, I know hindsight is 2020, but it seems exceedingly poor planning to have had universities, the APTA, and CAPT all come together saying we're going to make this big push. And the big elephant in the room that was not invited was insurance companies saying, what will you do once we do this? It seems like it was exceedingly poorly thought through that they were not included. Exceedingly so. And finally, argument number four, patients won't know the difference. I don't believe this is true. I don't believe this is true at all. I think patients that walk into a physical therapy clinic that's one-on-one with a doctor of physical therapy versus someone who walks into a clinic that isn't one-on-one with a doctor of physical therapy, they know. Now, if your entire business model operates on the idea of seeing 2 or 3 patients at the same time, yeah, of course the patient doesn't know. 80% of the time, the patient's actually being seen by a physical therapy assistant anyway. They're not really even sure what the physical therapist does different than the PTA, except they measure them once in a while. So by terms of proximity, of course the patient's not going to know. They don't see you enough to know. But if you're working one-on-one with a doctor of physical therapy and they take the time to educate you and to share with you why you have the condition you have and how you developed it, that's where your doctorate level shines through. But healthcare system doesn't incentivize that. The healthcare system incentivizes you seeing as many people as you can to get them better because we have numbers to meet. And that's not even just a financial thing of the company's got to get the numbers. No, There's so many people that are so hurting and so sick out there. We have to try and get as many of them in as the altruistic stance to help as many human beings as possible. There's that faction too now that we have so many people entering into their later years and needing help with physical therapy. Just to try and see everybody, you've got to be in there trying to get as many people educated and in and out as possible to try and make the body of your country as healthy as possible. But here's what some critics missed. These are some positives. Stroke rehabilitation outcomes significantly improved. That is, patients that had strokes, we got way better at treating them. Heart failure patients, we got way better at treating them. Cancer, we got way better at treating cancer. ICU, way better at getting mobility, getting them out of the bed and out of the hospital back home as fast as possible and in a healthy way, obviously, to help them get back to moving, which increased their chances of survival. Musculoskeletal research exploded and our understanding of the human body greatly expanded. All of this was in part because of the doctorate level of education that created a culture based on also research, which is big, it's beautiful. But this is also why the issue of cutting the federal funding is so confusing, because we've done all this work to become such a better educated body of doctors and get all this research done, and then the government says, yeah, but you're too educated, stop it. It's I'm sorry to laugh, but it is kind of funny where it's like, oh, yes, you're so educated. You're getting so many good outcomes for these patients. And all of these patients, these difficult patients, the stroke patients, the heart failure patients, the cancer patients, the ICU patients, the rare autoimmune disorders that we're having. You are so good at getting that, and they've gotten so much better, and their survivability is so high. But y'all need to stop that, so we're going to take away the money that learn. That's the paradoxically humorous part to me. The things that we exploded and got good at are definitely tied to the increased education level that we have that comes from the research, but it's just hilarious that that's the thing that we're going to cut. But to be fair, there are residencies out there in physical therapy that one could join post-doctorate program to go into a residency where in theory you could do a residency focused on stroke, a residency focused on heart failure, a residency focused on cancer, and etc. and etc. That's really the part that I think is missing, is that continuing education for PTs to specialize into these further areas. I'm not really sure the college degree is necessary to have to cover all those things. If we restructure the educational system, be like, hey, we're going to get you to an entry level PT, but you can always go and get continuing education as a resident or et cetera, and go and get to specialize in these things by going and either paying out of pocket or getting a loan or going and joining a certain organization and promising to be there for X number of years to get this continuing education. That's all something that's possible, and it really wouldn't require a loan. It's just completely humorous to me that the thing that we got so good at is also the thing that's going to be taken away. Anyway, when the APTA pushed PTs to doctorate standards, and we kind of succeeded at some of those things while massively increasing the debt and not increasing salary, it's interesting to me that the things we succeeded on are things that make us the most professional, the most complicated patients, and yet the BOE takes away that title and says we don't consider that a professional degree anymore. It's slightly humorous. And part of me thinks it really is just a word game. I don't think that the Board of Education doesn't think physical therapy isn't professional. I just think there are legal terms and amounts of money tied to the term professional. And that's why they took it away. Now, how has all of this impacted today's crisis? Did making physical therapy a doctorate level degree help or hurt the career in the current funding crisis? Things that fall under the list of that it helped. Direct access, that's where patients get to come directly into physical therapy offices. And states have passed that. Some insurances, of course, still don't want patients going directly into physical therapy, but there is the option for people to pay out of pocket, I guess, to go to physical therapy. It improved patient safety. It has significantly improved clinical decision making. That's for sure. And what I mean by that is knowing what is the best course of action to help treat a patient. It's helped massively with research, which then in turn is what helps the decision making process. And it has helped to some degree with physical therapy being intermingled and integrated into other disciplines in order to be more of a cohesive team effort to help patients instead of just a subservient technician. So if the physical therapist coming to the table with a doctor of osteopathic medicine and let's say a rheumatologist and an oncologist being at the table with all those people to help provide the best care for a patient instead of being isolating, left off the list, and not considered being important enough to bring to the table to help contribute. Say, hey, here's where the patient's struggling with this, this, and this. That is true. By making physical therapy a doctorate level degree, a lot of times they're invited to the table to be participating in that conversation, even getting better patient care. The things that it hurt. So we talked about, we did the positives first. The things that it hurt. Educational costs. This is the big negative. Insurance recognition. We never got it. Federal classifications for funding, and we just lost it. That also, part of what is not mentioned here as well, but besides the education, the insurance, and the federal classification, is the burnout. The APTA never accounted for and never adjusted for the changing healthcare landscape of the mid-thousands and then the late thousands and the early 2010s. And because of that, we got hurt by not actively lobbying enough to protect ourselves from either rate cuts or from being excluded from other things. So there's that part too. The irony of all this is that we trained physical therapists to be autonomous medical providers, but the federal agencies are still treating, and insurance agencies are still treating PT like a technical trade. So the issue isn't if physical therapy is professional or not. It very clearly is. The problem is it's a bureaucratic classification pushed upon PT. And it's a cultural understanding and a business understanding of what PT is that continues to be the problem. In the next episode, we're going to talk about student debt, tuition costs, and why PT education became so expensive. The things that we're going to talk about for this are going to be how the CAPT accreditation requirements came into effect, how they changed, clinical rotational issues, so like lack of places to get students into, to get internship hours, how the universities changed, and also how Medicare changed, and how all of these things led to inflated costs for PT students. So one last thought before I let you go, and it's going to go back to that classification issue. The reason why I'm doing podcasts like this is to help everyone understand what PT is. I'm trying to help get out there and help shape the cultural, the bureaucratic, and just the understanding of physical therapy in people's minds. We're a profession that's here to help you get better. It doesn't matter if we're considered professional or not by the government, because we are, at least currently. We are more knowledgeable than any generation of physical therapists that have existed before us. We're able and capable to get the best patient outcomes that have never before been seen in history. We're more educated and more trained than any other generation has been before us. And that to a degree, we don't care if people call us professional or not, because we know that we are. But to label us as a classification saying you're not as good, you're not as capable, and we don't recognize you as the same as fill in the blank of these other healthcare professionals we work with, and we're not going to treat you as such, and we're definitely going to make sure you don't get paid as much or reimbursed as much. That's where the PTs always feel left out, left behind, and there is no small amount of pain associated with that. So that's why I'm doing this podcast. I want to make sure that everybody knows what physical therapy is, what it's trying to do, and how it can help, and how it plays a role in this healthcare system. So thank you so much for watching and listening. Please don't forget to like, comment, and subscribe, and share this with everyone that you know. Now, everybody stay healthy, stay fit, and stay awesome, and I will catch you all in the next episode.